Welcome everyone to today's event on the deployment of COVID-19 to undermine sexual and reproductive health. I'm Katherine Franke from Columbia Law School in the Center for Gender and Sexuality Law at Columbia Law School, and we're just thrilled to have you join us today. This event is part of a series that we've been running in a really wonderful collaboration, partly with Columbia, on COVID-19 advancing rights and justice during a pandemic. It's a virtual event series, and if you go to our website, you'll see recordings of all of our past events. And it's been convened by the Columbia Law School's Human Rights Institute, Duke Law's International Human Rights Clinic, Columbia Law School Center for Gender and Sexuality Law, and Just Security. So the topic that we're going to be dealing with today is one of enormous urgency, of the ways in which COVID-19, the pandemic, and a kind of national emergency has been seized by both public and private actors as a way to limit access to reproductive and sexual health, but domestically in the United States and globally. It's a large topic to deal with in just an hour, but we have the most amazing people on our panel today who will be able to address from their vantage point and from their work how COVID-19 has been used as a kind of wedge to undermine reproductive and sexual health. So in the order of our speakers, our first speaker will be Brigitte Amiri, who is the Deputy Director of the Reproductive Freedom Project at the ACLU. She'll be followed by Quita Tinsley, who is the Co-Director of Access Reproductive Care-Southeast in Atlanta, Georgia. Quita will be followed by Melissa Murray, who is the Frederick I. and Grace Stokes Professor of Law and Director of the Birnbaum Women's Leadership Network at NYU Law School. And then finally, we'll have Eszter Kismodi, who is the Chief Executive of the journal Sexual and Reproductive Health Matters. So Brigitte, why don't you get started with us, please? Oh, and wait, before I say, if you have questions, please put them either in the questions box at the bottom of your screen, or you can tweet them to hashtag COVID-19 justice. And we will do our best to bring your questions up at the end of the panel. I may be in the position of combining various questions, but please bring them in, send them to the Q&A or tweet them to hashtag COVID-19 justice. All right, sorry, Brigitte, go ahead.
Okay, thank you so much for having me, and thank you everyone who's joining. So what I'm going to do is give a little overview of the different challenges that we've had to launch against states that have tried to use the pandemic as an excuse to ban or heavily restrict access to abortion. I'll let you know where those challenges generally stand now and what they mean for the future. And I'm going to use Ohio as a case study for a very concrete example of what has happened in one of these cases. So at the outset, I'll also say that I naively was not prepared for this, and I'm not sure anyone was, but quickly after states started implementing and issuing executive orders that restricted certain medical procedures, there were states that seized on those executive orders to say that abortion should be banned. And as a result, 9 states faced legal challenges to their executive orders that restricted procedures. And those states are Ohio, Texas, Arkansas, Alabama, West Virginia, Iowa, Louisiana, Tennessee, and Oklahoma. And the ACLU has been involved in many of those challenges, and our partner organizations, the Center for Reproductive Rights and Planned Parenthood, have also been involved in many of those challenges as well. And it's no coincidence from that list of states that those states that have used the pandemic to try to ban or restrict access to abortion are the same ones that have always passed legislation to try to restrict or ban abortion. And in a number of those states, we actually have current challenges to legislation banning abortion at the earliest stages of pregnancy, for example. And conversely, states like New York, which is at the epicenter of the epidemic, did not seek to ban abortion. And so I think that's really telling in and of itself. All of these challenges involved executive orders that banned non-essential or elective procedures. I'll use air quotes there, elective procedures. The terms of the executive orders were slightly different in every state. They were also different in terms of the duration. Some had expiration dates, some were open-ended. In all of the states, however, that we've had to challenge, the hostile politicians have used the executive orders to try to ban or restrict access to abortion. Ostensibly, these executive orders were developed to try to preserve personal protective equipment, or PPE, I think is a term we all now know, which we didn't know before, and that's gloves, masks, gowns, etc. They were also designed to preserve hospital capacity. They were also designed to ensure social distancing. So that was the ostensible government interest in these executive orders in the first instance. And that comes up in the context of our constitutional challenges when you see the government's defense of why abortion should be restricted or banned in light of the pandemic. Right out of the gate, the American College of Obstetricians and Gynecologists and the American Medical Association had statements out saying that abortion is an essential medical procedure. It cannot be delayed without risking a patient's health and should not be postponed given the pandemic. So that was a very strong statement from the leading medical communities on our side, saying you can't ban abortion during the pandemic without devastating consequences. And while abortion is one of the safest medical procedures in the country and much safer than childbirth, each week of delay increases the risks associated with the procedure. And so obviously not in addition to the delay, the psychological impact of someone being delayed access to an abortion that they have decided to have, you also have the increased risks associated with the procedure. And unlike other procedures, pregnancy can't be paused. You can't just say, just stop being pregnant during this pandemic. You're going to need healthcare one way or the other. If you've decided to have an abortion, you should be allowed to have the abortion. And if you're carrying the pregnancy to term, you will need other medical care, whether it's for prenatal care, eventually delivery, for miscarriage management, et cetera. So, our position all along, as was the major medical organizations, is that abortion is essential and cannot be delayed. So the cases really followed a similar pattern where temporary restraining orders were secured by district courts on an emergency basis. And in many cases, the other side of the state took emergency appeals of those temporary restraining orders to the courts of appeals. And then we were simultaneously litigating the preliminary injunction in the district court. So while these cases involve, the intersection of medicine and constitutional law, these were also civil procedure exams in the making. So I'll take Ohio as an example. So Ohio issued an executive order prohibiting non-essential surgeries, which the executive order defined essential medical procedures as those that cannot be delayed without undue risk to the current or future health of patients. Medication abortion was not affected. Only surgical abortion was affected in Ohio. And the Attorney General decided to launch an investigation into the clinic's compliance with the executive order. Some of the clinics that we represent were inspected for 2 days after the executive order was announced. Governor DeWine had a press conference in which he said he thought only abortions necessary to save the life of the patient could be performed. And there were criminal penalties as a result of violation of the executive order. So we felt we had no choice but to rush into court and seek a temporary restraining order, which luckily we secured, that allowed abortion providers, like any other medical provider, to use medical judgment to make a case-by-case determination of whether an abortion could be delayed safely for the patient. And so that's basically the temporary restraining order we got that allowed that medical judgment to take place. The state sought mandamus, appealed the temporary restraining order, which typically you're not allowed to do, and sought an emergency stay of the temporary restraining order. The Sixth Circuit Court of Appeals dismissed the appeal, saying that they lacked jurisdiction over an appeal of a TRO, that this was not an extraordinary circumstances, which they should keep the case, keep up the appeal. Subsequently, we got a preliminary injunction, largely tracking the temporary restraining order and really demolishing the state's arguments about why that this was necessary to effectively ban abortion, surgical abortions during the pandemic. And I think the court was really offended that the state, for example, tried to equate abortion with a facelift. And there's some just really wonderful language. I'll generally stop there and say that the executive order was repealed on May 1st. So abortion provision in Ohio is back to 100%, as is true for many of the states where there have been challenges. The executive orders are in states where those states are opening up. You know, in my mind prematurely, but as a result, the executive orders about surgeries are being withdrawn. So there's a full abortion provision in Ohio, Texas, Alabama, West Virginia, Iowa, Louisiana, and Tennessee. Arkansas and Oklahoma are the ones that are still in some rough spots right now. So I'll stop there, and I'm passing it back to you, Catherine.
Thank you so much, Brigitte. And I will remind you, if you have questions, please tweet them to hashtag COVID-19 justice or put them into the question box at the bottom of your screen. Quita, please give us a sense of what's going on in Georgia and with your community.
Hi everyone, my name is Quita Tinsley and I'm the co-director of Access to Reproductive Care-Southeast, or ARC-Southeast. And we are a reproductive justice organization that does abortion funding and provides practical support to people seeking care in 6 states across the Southeast. So we're based here in Georgia, however, we also serve Alabama, Florida, Mississippi, South Carolina, and Tennessee. So as Brigitte was naming the states that have put policies in place to make abortion care non-essential, 3 of those states are within our service region. So today is actually a very exciting day for ARC-Southeast. It's our 5th anniversary. We were founded on May 5th, 2015. It's an interesting time to be celebrating an anniversary, or a fundiversary as we call it. But I think this time now more than ever shows us why abortion funds are important and critical to ensuring that people have access to abortion care. So I want to give a brief overview of ARC-Southeast, who we are and what we do, and what is happening here in the South and why it's so critical to have a community response to barriers to abortion care. So ARC-Southeast was founded in 2015, like I said, by 3 Black women who actually met each other while working in a local abortion clinic here in Atlanta. And every day they were witnessing primarily people of color, low-income folks from rural areas being so impacted by abortion barriers that they weren't able to show up to their appointments. So oftentimes it was a lack of funding, sometimes it was not having a ride, sometimes it was not having a place to stay. And these were all reasons that were preventing people from coming into the clinic. And so they decided to start an abortion fund to be able to show up for Southerners to ensure that they always had access to care. And it's important having an abortion fund in the South. So we take a different approach to abortion funding. We take a regional approach, because being in the South, the reality is what happens in one state has an impact on all of the other states as well. So when thinking about abortion care or access to abortion care in the Southeast, 95% of counties in the Southeast do not have a known abortion provider. And 88% of our callers have Medicaid or uninsured. So we see that there's like a lack of access to abortion care, but there's actually an overall lack of access to healthcare in the South. And it's important to root that like healthcare, abortion is healthcare. And when we think about that lack of access in the South and what's happening with COVID, there's an overall lack of healthcare for folks living here. And the barriers that exist, so 1/3 of our callers have to travel outside of their home state for care. And when we think about Medicaid expansion, so Medicaid does not cross state lines with you, but the reality is that most states in the Southeast, all of the states that we actually serve, have not expanded Medicaid. So that's in two senses. So they have not expanded Medicaid under the Affordable Care Act. So many folks do not have access to health care, but also thinking about Medicaid has not been expanded, so state Medicaid programs do not cover abortion. So anytime low-income folks decide that they need or want abortion care, they are being forced to pay out of pocket to access that care. And with what's currently happening with COVID, so as Brigitte talked about, all the states who are putting these barriers in place, people are having to travel further and wider to access care and are being forced to travel across state lines. So immediately what we saw, what was happening in Tennessee, which had a similar policy in place as Ohio, surgical procedures were not allowed to happen anymore because they were deemed non-essential, and only medication abortion was allowed to happen. So anyone who was past the limit to be able to access medication abortion was having to travel out of state for care. And Texas and Louisiana are not in our service region, but however, as those states put in their executive orders, we start to see people traveling from out of Texas and Louisiana into our service region for care. And when we think about that, it's not just people having to travel. So in a normal sense, when there isn't a global pandemic happening, people are having to figure out, where do their children go? How will they be able to take time off of work? How will they not only be able to afford their abortion procedure, but also thinking about gas, lodging, prescriptions, and all of these things as well. And during a global pandemic, all of these things become even more complicated for people. So if your childcare facility is closed because of COVID, really, where do your children go? If states are starting to close their borders to prevent the spread of COVID, where can you even access care outside of your home state, which is definitely something that we saw happening in Tennessee, with the neighboring state of Kentucky starting to have a stronger approach to combating COVID. So in this moment, so we're like, what is ARC Southeast's approach? So we're still doing what we do. We're just doing it a little bit differently. And in this moment where people are talking about mutual aid, we think it's important for people to really remember that abortion funding has always been mutual aid. And now is an important moment for all of us as community to think about what is our personal responsibility to show up for each other. And how can we continue doing mutual aid, not only outside of this moment, but in the future as well. So as far as funding, so ARC Southeast, we fund abortion procedures. And in this moment where people have been losing their jobs, have been having additional family members in the house, children being in the home, is causing financial hardships across the board with people who are already having gaps when trying to access care. So when thinking about that, we've had to increase our pledging amounts that we've been supporting people with. So on average, we typically pledge people $50 to $75 to support with their abortion procedure. We're at a minimum supporting people with $100 per their procedure to ensure that they're able to access care. And I like to throw this number. So in our first 6 months of operation, when we opened in July of 2016, we funded $20,000 for abortion funding and practical support, and we were so excited. But in this year, we've funded the first 3 months of this year. So as we're thinking about COVID, really March was like the beginning. But in the first 3 months of this year, we funded over $130,000 in abortion funding alone. And in the month of March, when we began to really see the spread of COVID happen and state responses, we funded $54,000. And that is just a fraction of the actual need because we are not covering people's entire procedure, which starts at about $500 at the earliest in their pregnancies. And also, ARC Southeast provides practical support to people seeking care. So when people need rides, lodging, childcare, support with prescriptions, we also support with that as well. And in typical times, we usually have a network of volunteers of over 100 folks, primarily within the Southeast, but across the country as well. We're able to support with giving folks those rides, opening up their home for a place for folks to stay at no cost. However, with COVID, we've had to shut down our practical support program, as many other abortion funds have across the country, just to ensure that our volunteers and our callers remain safe. which means that we're having to pay out of or we're having to support people with paying for hotels so that they don't have to pay out of pocket for it, paying for their hotels, supporting with getting their rideshare costs covered, supporting with their childcare costs, because now often people are having to turn to family members to take care of their children while they are accessing care. And I keep talking about childcare because 76% of our callers are already parents. And we know that most people who have abortions are already parents. So not only are they thinking about the pregnancy that they currently have, but they're thinking about continuing to support the children that they already have. And we also, in addition to the funding and practical support, we do advocacy and education, because when we think about how states are trying to deem abortion as non-essential, this is a part of stigma. And so abortion, especially in places like the South, abortion is kind of like the word that you don't say. And it's reflected in the lack of clinics across the South as well. But it's important that we talk about abortion access and the lack of access, and the reality that 1 in 4 people within their lifetime will have an abortion, at least one abortion. So many of folks are having abortions, and it's not a dirty word. We have to bust the stigma, and we also have to think about how do we actually show up for each other. So ARC Southeast, the funding that we do is not some magical money that we pull from a tree somewhere, right? It's actual community support. So folks actually donate and fundraise to support other folks in community accessing their abortions and opening their homes and doing what they can to support people and getting the care that they need and want for themselves and their families. And yeah, I'll stop there, and I can talk a little bit more. If people have questions about how they can show up, I can let you know the ways that you can show up for abortion care in the Southeast of the country.
Catherine, you're on mute.
Thank you. Questions, tweet them to hashtag COVID-19 justice, or put them in the box at the bottom of your screen. Professor Murray, please take it from here.
Right, thank you. Thanks for hosting this, Catherine, and to the center. This is really fantastic. And I don't want to belabor what Brigitte and Quita have said. I will just say that the pandemic has provided what I call COVID opportunism for states to continue what has been a pretty rapid campaign to continue limiting access to abortion over the course of this pandemic. So it's not surprising that it's happened. It is surprising that it's happened with such alacrity. And so just a couple of things I wanted to highlight about the reproductive rights landscape. One issue is that we're looking at just the pandemic, but we should be thinking about after the pandemic. And if these laws go into effect, if we see more shuttering of abortion clinics because of the pandemic, we're unlikely to see them reopen once the pandemic is over. We saw this in Texas during Whole Women's Health. When a clinic shutters, it's very hard to get it back online. So the question is not just what happens during this time, but what happens afterward. Quita mentioned some of the issues surrounding those with children already at home. We should also think about those persons who are pregnant, who are teenagers and are home with their parents, no longer at school, the difficulties that they'll have accessing abortion care because of limited courtroom access for judicial bypass, their inability to confide in their parents about their situations. All of those circumstances will be exacerbated because of the pandemic. Brigitte also mentioned the whole question of the states and denominating abortion non-essential care. What I thought is really interesting about some of the language that the various state officials have used is that they keep likening abortion to quote unquote non-essential procedures like plastic surgery, brow lifts, tummy tucks. And it's a constant refrain from some of these states. I think that's purposeful, and it's part of an ongoing narrative and a sharpening of a narrative that is meant to liken abortion care to the kinds of quote unquote vanity projects that individuals can engage in, and to make clear that this is not a kind of healthcare, but a sort of selfish and not self-abnegating choice that good people would not make in a situation like this one. So this is not just an opportunity to limit abortion, but to also press a narrative in which those who seek abortion care are seeking to avoid the kinds of global responsibilities that good people would actually assume. So I just wanted to sort of flag all of those things, but I wanted to also pivot to a question that's not really a question of reproductive rights, but maybe a broader question of reproductive justice. And those who work in a reproductive justice frame really emphasize the idea that reproductive rights and justice is not just about access to contraception or abortion, but rather access to all of the conditions in which you can live your reproductive life in conditions of economic security and physical safety. And so one of the things that I think the pandemic has highlighted is that we don't really expect a lot from the state in providing the kinds of material conditions in which we can exercise a kind of physical safety and economic security in our reproductive lives. If we think about the last 20 years and the different movements that have been successful, the gay rights movement, the marriage equality movement, a lot of those movements were demanding of the state the simple question of recognition. So we saw in the marriage equality movement, the entire question was whether the state would step up and recognize same-sex couples as legal unions. And then the adjunct cases that followed the marriage equality movement were questions of whether or not same-sex couples would be recognized as parents for purposes of birth certificate registries. The question is purely one of recognition. That's the obligation that is put on the state, to recognize individuals and their loved ones as families. What if we required more of the state than simply recognizing us as family members? What if we had or expected of the state a kind of affirmative obligation to provide those conditions of economic security and physical safety that made it easier for families and individuals to live their lives? And I think the pandemic is making clear that we actually don't have those kinds of expectations of the state and state actors. The one real subsidy that we have seen from the state, and that which has vanished during the pandemic conditions, is schools. So right now, a lot of parents are at home. I'm at home working from home with my children here. And it's become all too plain to me that school is actually the one kind of subsidy for childcare that we get from the government on a regular basis. There's obviously other forms of subsidy, but school is sort of a universal subsidy that people with children, people who are caring for children have. And in this pandemic condition, we can't expect that anymore. And the question is, should we just expect school, or should we expect even more from this? We are now talking about reopening all of these different states, and there's been no provision for the reopening of schools. Schools are going to remain closed, and that just highlights we have an expectation in this country that our economic productivity should be privately subsidized by the work that individuals and families do. So right now we're seeing this in stark relief. If we're going to reopen, and we're going to reopen without schools, there is some expectation that there's someone in the home who can care for children who right now can't care for themselves. And we're just moving forward as though that's an assumption. In a lot of families, that will have a very gendered cast. Those who will be staying at home or who are expected to stay at home with children are likely to be women, or those who make less in the family economy, which historically has been women. And we're going to see the kinds of gaps, the inequality in gendered pay, the inequality in workforce participation, all of that's going to be exacerbated by this pandemic as we begin to reopen, and we reopen without the kind of safety net, even the thin safety net that we've experienced over the last couple of years. And so I just want to go back to something that Quita says. We have been showing up for each other over the last 20 years, and we'll continue to show up for each other. But showing up for each other is really a form of privatizing dependency. And we've done that because the state hasn't been there. And so I think one of the real opportunities of this crisis is that it has shown us that privatization can only get us so far. We can only show up for each other in ways that are meaningful so long as the outside conditions are receptive to that and hospitable to it. And these conditions aren't. So what are we going to do in a period of real disaster? What are we going to demand from the state as we go forward? It can't simply be a question of showing up. I think this is a moment where we should and can demand that the state show up for all of us. So I'll stop there.
Thank you, Melissa. That was really helpful. Eszter. You're on mute, Eszter.
Okay, thank you so much. And I'm very pleased to be here. And I would like to talk a little bit from a global perspective, especially using information and data that is increasingly available from low and middle income countries, and use the permissible limitation of human rights as an entry point of the discussion as they are applicable to the COVID-19 crisis. especially in the context of the recent statement of the Human Rights Committee issued on the 24th of April, and in connection to the Syracuse Principles on the limitation and derogation provisions in the context of the International Covenant on Civil and Political Rights that has been applied to many other conventions and nationally as well. The recent statement warns states to consider the following conditions when exercising emergency powers. There has to be a strict necessity and proportionality of any derogating measures taken. The conformity of measures taken with other international obligation needs to be investigated, and measures cannot be discriminatory, and derogating non-derogatable rights is prohibited. I'm just listing some of them that I'm exploring here. These conditions correspond with the principles of the Syracuse Principles, reaffirming that the restrictions on human rights may be justifiable only when they are, and I'm just listing a couple, based on scientific evidence, directed toward a legitimate objective, strictly necessary, least intrusive, and neither arbitrary or non-discriminatory. Recent studies, including those presented by recent MSI, Mary Stubbs International Study, suggest that COVID-19 epidemic has rapidly and dramatically altered the programming landscape for sexual and reproductive health and rights in low and middle income countries across the globe. High quality contraception, abortion, and post-abortion care services were forced to close due to strict lockdown, like in the US, or are operating on reduced hours. Mobile outreach teams who primarily deliver contraception in remote, rural, or underserved urban locations have suspended in several countries. Channels are affected by shortages of products in the supply chain, and there is documented reports of increased stigma towards healthcare providers and against clients who have used those health systems. I would like to explore a little bit the numbers. There are various calculations suggesting a detrimental impact on sexual and reproductive health and the life of women and girls due to state actions intentionally obstructing the provision of these services or failing to act in a manner that can enable the provision of these services. As a recent Guttmacher estimate in low and middle income countries shows, in a case of 10% proportional decline, that seems to be an underestimate, in a use of short and long-acting reversible contraceptive methods, due to reduced access would result in an additional 49 million women with an unmet need for modern contraceptives and an additional 15 million unintended pregnancies over the course of the year. Even in a case of modest decline of 10% in coverage of pregnancy-related and newborn health care, an additional 1.7 million women who give birth and 2.6 million newborns would experience major complication but would not receive, if they don't receive the care needed. This would result in an additional 28,000 maternal deaths and 168,000 newborn deaths. If abortion was considered a non-essential service, so that 10% of women who would normally have a safe abortion instead resorted to an unsafe method, and an additional 3.3 million unsafe abortions would occur with additional significant number of deaths. I'm sorry about the numbers, but we listen endlessly to the numbers in relation to COVID-19 on a daily basis. It's important to listen to the numbers as a result of estimates as well. Based on increasingly evidence-based information such as this one, the obstruction of safe abortion and contraceptive services or the failure to provide access to them would not meet the Syracuse principle requirements. One, the restriction on denial of services would not be based on scientific evidence. We have plenty of evidence from all over the world that shows that abortion is a time-sensitive service with delays and denials leading to unsafe abortion. Two, in terms of investigating necessity. As Jamie Todd-Kerr and Pajal Shah points out in their recent paper, given the time sensitivity of abortion and the health risk, prohibiting access to abortion is a disproportionate response. Therefore, abortion needs to be considered as an essential medical service. Looking at the least intrusive and restrictive availability test, good practices from various countries now show that the state could facilitate self-managed medical abortion, emergency contraception, for example, through telemedicine, by waiving requirements that entail one or more clinical visits, including mandatory waiting periods, providing telemedicine counseling, and male delivery of abortion and contraception. Programmatic response in low and middle income countries also shows that the response may include the exploration of partnerships with online pharmacy retailers, and also investigating whether these pharmacies can be points for sale and distribution of essential reproductive health products, as pointed out by Catherine Church in her upcoming paper. When we look at the test of non-discriminatory measures, state arbitrary actions or their failure to provide services in alternative ways clearly discriminatory, since, as previous speaker pointed out, it affects only those segments of the population, women and girls, who need abortion, contraception, and safe maternal health services, and it is discriminatory against rural women and adolescents, for example. Continuing with the examination of the arbitrary and discriminatory nature of state actions takes us to the marginalized population, such as women living with disability, transgender people, sex workers, people living with HIV experiences. The common experience of these populations, and it's an interesting pattern that different population groups are showing, and it has been, for example, explained by Mauro Cabral and Lizzie Kiyama in a recent SRHM webinar. The pandemic is not introducing radically new challenges in the lived realities of these populations. The general population across the globe is now experiencing that many of these marginalized population live in, such as adolescents, persons with disabilities, persons living in rural areas in humanitarian setting, members of the LGBTQI communities. However, when it comes to their experience, it's aggravated. So just two examples. When it comes to the needs and rights of people living with disabilities, there are assumptions, for example, that increased use of technology in delivering crucial messages, whether it's related to hygiene or the provision of sexual and reproductive health services through social media, can reach people with disability, for example, those with hearing impairment. Restrictions on transportation make services even more difficult to reach for people with physical disability. Increasing data shows that women and girls with disabilities face increased sexual violence, particularly those with intellectual disabilities, and those who are in isolation and social distancing in confined homes with their abuser, and it's disproportionately affect women with disabilities, even if the whole population, the women and population is facing increased domestic violence. In several countries, trans people, sex workers, lesbian and gay population experience aggravated police brutality, find themselves in a situation of extreme vulnerability. In many countries, such as in the US, Brazil, Hungary, waves of institutionalized transphobia increases and homophobia. In these cases, restrictive measures in the absence of provision of alternative solution does not meet the proportionality test and certainly fails non-arbitrary and non-discriminatory requirement, in my opinion. And my last short point, the misuse and overuse of criminal laws have been already found to fail the Syracuse principles, as it has been investigated, for example, in relation to the HIV response, as it has been pointed out by Emily Christie from UNAIDS in the same webinar. Criminalization, and it has been deployed in relation to COVID-19, can further marginalize those whose sexual and reproductive action, behavior, expression already criminalized and who are most vulnerable. Adolescents, people who use drugs, sex workers, people with same-sex sexual orientation, and trans people. While states are allowed to exercise emergency action, criminalization in the broader case, and especially in these cases, certainly fails the test of necessity, evidence-based proportionality, and non-discrimination. So as a conclusion, creating an equitable system that promotes gender equality and non-discrimination is a human rights imperative. Experience of good practices now from all over the world show that we need a multi-stakeholder and multi-sectorial action that is not just a lip service, and global advocacy to reinstate human rights. Thanks.
Thank you so much, Esther. So much to talk about from all of your presentations. I will just remind those who are viewing to put your questions in the Q&A box at the bottom of your screen, or tweet them to hashtag COVID-19 justice. I want to start off, Bridget's going to have to leave us a little bit early because she's got another pressing meeting at her office or virtual office. But I want to start off with a question with you, Bridget, which is to give us some insights about the argument that's going to be held in the Supreme Court tomorrow. You know, this week, the Supreme Court has started doing something unprecedented, which is to take oral arguments over the phone. And so we can listen in live to the argument, and the case being argued tomorrow is another of the Little Sisters of the Poor challenges to the Affordable Care Act's requirement that contraceptive coverage be included in employer health plans. Is there anything we should look for tomorrow in particular, Bridget? Or is there any way in which sort of the specter of COVID-19 and this pandemic and the sense of certain kinds of constitutional rights seems more suspendable, more sort of fragile in this period than others do? And might that affect how the case is argued or decided by the court?
Yeah, so thanks, Catherine. So the argument tomorrow, as Catherine mentioned, Trump versus Pennsylvania, the Little Sisters of the Poor intervened, and the question is whether the Trump administration rules that would allow any employer to use its religious beliefs to take away contraception coverage that is otherwise guaranteed by the Affordable Care Act would be allowed to take effect. These rules have not been allowed to take effect. The courts have blocked them. And so the question for the Supreme Court tomorrow is whether they can be allowed to take effect. And the actual arguments are under the Administrative Procedure Act. And so it's kind of nerdy, but one of the fundamental questions involves the Religious Freedom Restoration Act and whether religion can be a justification to be wholly exempt from the contraception coverage requirement, or whether the accommodation that the Obama administration developed that allows employers that have a religious objection to providing contraception can basically take themselves out of the equation, and the insurance company steps in and provides contraception. So I certainly think in a pandemic, people should be all that more concerned about taking away healthcare coverage for any service. Also, that includes contraception as well, for all of the reasons that folks have talked about today, and more so. And so it'll be interesting to see. And the things that I'll be watching for is there are two members on the court that weren't there in the prior iterations of this case. This is the third time the Supreme Court has heard arguments on the contraception coverage requirement of the Affordable Care Act. Justices Gorsuch and Kavanaugh were not on the court in those prior rulings. So I'll be paying close attention to their questions.
Great. Melissa, do you have anything to add about what to look for tomorrow as our law professor?
I would also say that it's true that Justice Kavanaugh and Justice Gorsuch weren't on the court when those earlier cases, Hobby Lobby, and then the Zubik cases that came after it were argued. But Justice Gorsuch was on the 10th Circuit when that circuit heard what became the Hobby Lobby case that went up to the Supreme Court. And he was part of a majority at the 10th Circuit that voted to allow private corporations to exercise their religious freedom to exclude their employees from the coverage of the contraceptive mandate.
Okay, thank you. For the group, any of you who might know this, I have two kind of twin questions about data and the way that COVID-19 and the government and other responses to it might affect access to healthcare. One is whether you are aware of issues with trans people having greater problems accessing transition-related care as non-essential services, as Brigitte described it earlier as kind of, or maybe it was Melissa, now I can't remember, as a vanity, a kind of vanity or selfish kind of healthcare. And then secondly, whether we've seen increased numbers, and maybe it's too soon to say it, but increased numbers of people who are having unwanted pregnancies because they are locked at home, perhaps in greater connection or relationship with people who may be engaging in sexual activity with them against their will. So do we know either of those, any data about either of those for anybody who might know this on the panel?
From the global perspective, we are increasingly receiving data from the trans communities all over the world. These are not rigorous studies, but quick, rapid assessments, but coming really from all over the world, how trans people are not receiving services in many parts of the world. It's really not considered as an essential service. When in fact, again, practice shows that those services can be cheap, easily available. There can be, like contraception, there can be provided in alternative ways. And the stigma and discrimination in terms of the prioritization process in relation to trans care, it's really prevalent. I think we cannot consider necessarily trans-related care in a homogeneous way. There is access to cosmetic surgeries, there is access to trans surgeries, there is access to hormonal contraception. Some of them may take priorities in certain settings, but certainly hormonal treatment should be available easily in alternative ways. And we are reporting, and again, how there is an intersectionality between violence, stigma, and access to services for the trans population is increasingly documented. In terms of violence against and domestic violence and sexual violence, WHO and FIGO and many local and international institutions come up with increasing data on detrimental effect of the situation on domestic violence. There are good practices in terms of availability of shelters in alternative ways, but there is increasing evidence shows absolute ignorance by state as well to addressing the problem.
Right, right. Anyone else want to weigh in on this issue? Okay. Really great question that we had that came in over the Q&A has to do with whether there's been any perhaps positive effect of this whole situation and the limits that are placed by state actors on access to what are seen as non-essential surgeries or medical procedures for strengthening medical abortions or abortions outside the surgical settings and strengthening access to telemedicine. Are there workarounds that we're seeing in states where there are constraints on access to surgical abortions that we might be able to build on as we go forward? Brigitte, it looks like you're nodding. Do you want to answer that?
I mean, it definitely presents this opportunity, right? In general, there's been a move towards telehealth in general. Unfortunately, a lot of states that heavily restrict access to abortion also have state laws on the books that say that abortion has to be carved out of the telemedicine that is permitted in those states. But I think it exposes that the disingenuousness of that position, that somehow abortion is different than everything else, particularly in this time where a whole bunch of different types of practitioners have been moving towards telehealth. So I don't have a great answer in terms of kind of how that translates, but I think that all of this kind of shows the hypocrisy of carving out abortion, and unfortunately in those states that have capitalized on the COVID pandemic to restrict access to abortion, many of those states also have laws that says that abortion can't be done through telemed.
Right.
A couple of states have actually specifically denominated abortion as outside of those non-essential services that can be limited during a pandemic condition. So I think New Jersey and New York are among the limited number of states that have specifically done that. So that's something I think that's encouraging. A note about telemedicine. Telemedicine is a great workaround for some of this, and certainly for self-managed abortion care, but it also, I think, exacerbates some of the inequities that we see in the provision of healthcare, or just generally the inequities that can occur from individuals not having access to bandwidth or Wi-Fi. I mean, so to have telemedicine, you actually have to be digitally logged in and online, and there are a number of communities, and we're seeing this in the education context, where Wi-Fi access is actually a luxury and not an expectation. So again, telemedicine is a workaround, but it also may exacerbate some of the inequalities we're seeing.
Thank you. Just one second, Esther. Related to the one of Melissa's comments when she began just a moment ago, are there examples that any of you could cite of within the US or internationally that provide a positive example of a framework for protecting reproductive justice and access to reproductive and sexual health care, as opposed to the negative examples that we've been spending more time on now?
I mean, I'll just say before I have to jump off, you know, unfortunately, that's generally not how our federal constitution or our state constitutions are set up in terms of these positive rights versus negative rights. But there are some state constitutions that provide greater protection for abortion and contraception than the federal constitution, and some state constitutions that also have protections for health in general and education. So there are a couple of state constitutions that I think could be looked to for broader protections. But you know, generally, our U.S. system is often one of negative rights versus positive rights, or so I was taught in law school. But I defer to the professors who can expand on that. And with that, I'm going to have to jump off. I'm so sorry, but thank you so much.
Brigitte, thank you for joining us, and thank you for all the work you're doing. I know it's a tough time.
Thanks.
Esther, did you have a comment you wanted to make earlier?
Yes, I think there's an excellent blog written by Christina Zampas, and now there is more and more information about it, that for many, many years we are advocating for the elimination of unnecessary barriers in relation to accessing services that are not justified on the human rights or the public health grounds, such as waiting periods for abortion, prescription only access to emergency contraception, authorization requirement for married women and adolescents, and many states and local authorities recognizing that the confinement, or actually in confinement, these barriers make accessibility for women and especially for adolescents impossible to access those services. There's no way that adolescent can sneak out 5 times to get permission from a committee to get safe abortion services. And there are different settings, including in different parts of the globe, when actually these requirements are suspended, and including prosecution and criminalization of certain use of services. So actually it's a very positive time to show that we can live without those arbitrary barriers in relation to the services.
Quita, I want to address another question that we're getting from our viewers to you, and particularly in response, invite you to have a response to something Melissa Murray mentioned in her comments about the kind of double bind of building out mutual aid in a way that we show up for each other. As Melissa said, well, that's partly because the state doesn't show up for us, and we don't have adequate resources to fully enjoy reproductive care and sexual health care and our reproductive and sexual selves. Do you remain convinced that it's the private sector that we should look to civil society, to our communities as the primary source of support? Or how would you imagine us building out both private and public resources collaboratively in an ideal situation, or at least a more ideal than the one we're in now?
Yeah, thank you for naming that, Melissa. Yeah, I think it's important to, I honestly think of it as like a both and, right? The reality is abortion funds only exist because the failings of the state. And the reality is abortion funds primarily support people who are low income, folks of color, queer and trans people, young people, people who historically have always been failed by the state, as Eszter noted, that folks like myself or other folks in my community have always been failed by the state. And so that's why we build these mutual aid networks and community services to support each other through the failings of the state. However, that doesn't mean that we should not be pushing the state to actually not only recognize, but actually support folks in community. So for me, when I think about the work that ARC Southeast and other abortion funds do, is we're pushing folks in community to model what we actually want our governments and states to do. So I want my taxpayer dollars to cover abortion access and contraceptives. And until my state actually recognizes and makes that law, I'm willing to do that. And I'm asking other folks in my community to make that commitment as well until our state makes that commitment itself. Sometimes I'm a bit pessimistic and thinking, especially being in the South, right? I mean, historically, the South has not always taken a stance of actually supporting human rights through their policy. But until that day comes, I will definitely do all that I can to support people and hope that other folks join me as well in doing that. Because when we think about what's happening in the South, there's an overall lack of access to care. And as I can't remember who noted it, but like a lot of the states in the South that have these abortion bans in place that were put into place during COVID are beginning to open. And so that's why these policies are no longer in use, because the states are reopening, which is further putting people of color, low income folks, and folks living in rural areas in further danger of being exposed to COVID. So the state of Georgia reopened recently, where I am, and there have been some initial reports that there's a spike of 2,000 recently reported cases of COVID after the state reopened. And so we know that what's happening here in the South in response to abortion access and in response to COVID, this push to reopen our economy is not a people-centered model. It's not actually about making sure that folks who are low income have what they need, because the reality, our unemployment process would be better, and we would actually have the money to support people so that they don't have to work during this time and don't have to expose themselves or their families in order to reopen the economy.
Right.
So yeah.
Melissa, do you have any response to Quita's comment there?
Yeah, I think that's exactly right. I mean, Quita and everyone who's doing the work of these abortion funds are doing it in the absence of state support, and obviously state support would be really important, but even then I think you need some kind of private supplement, and the work that you're doing is vitally important, both in the absence and in the eventual possibility that there is more in the future.
Right. We just have another moment or so. So the last question I'd like to pose to any or all of you to answer in the spaces where you're working is the effects of COVID-19 on access to not just reproductive, but sexual health care, and particularly HIV testing and testing for STIs. And that's been suspended in many contexts as well. Obviously, a hugely important form of sexual health care that can save lives. And may in some circumstances be the absence of getting HIV treatment or testing can be more dangerous than COVID. And so do you have any experience or thoughts about what's going on in your communities in terms of the suspension of access to HIV related and other STI related care and testing? Eszter, you're having a thought.
Yes, I think No, I think there is excellent data coming out and analysis from UNAIDS in this regard, and there is an increased documentation on how people living with HIV do not have access to treatment and to treatment, and solutions also are being promoted, how to overcome these barriers and how to make sure that the supply chains are undisturbed in various. So this is where also the due diligence of state applies, when very often those supplies are provided through the private sector. So how the state has an obligation to make sure that those private sector channels that are failing to provide services are delivered through state channels as well. And I think it's again, when it comes to key populations, sex workers, people who use drugs, trans people, it shows the intersectional discrimination what they are facing. They criminalize, they cannot access services, they cannot access drugs, the treatment that they need. So I think there is a really increased documentation, and the voice of the people living with the HIV community is increasingly heard.
Okay, we are tragically out of time. I want to thank Brigitte Amiri, Quita Tinsley, Melissa Murray, and Eszter Kismodi for joining us today to talk about these critical issues. So much more we could talk about, but I think we covered some nice ground in this hour. This webinar has been recorded, and if you would like to see it, it will be on the website with closed captions for those who would want or need them. Soon, today or tomorrow morning. You could just Google COVID-19 Justice Series and find the link for this recording. We will have another event on Thursday, same time, same bat time, 12:10 p.m. On the East Coast. And this event will also be critically important, COVID-19 and the rights of persons with disabilities. So please tune in for that event. There'll be much overlap with some of the discussion we had today, but of course those speakers will take the discussion even further. Thank you so much. Be safe, everyone. Be healthy, and thank you for joining us today.
Thank you very much.